Demonized and suppressed by the war on drugs, psychedelic medicines are making their return, and we're here to bring you the latest in scientific research and therapeutic practices involving psychedelic medicines from psilocybin to ayahuasca to DMT and beyond. This is the Psychedelic Medicine Podcast.
Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and today we are going to be discussing the possible benefits of a non-hallucinogenic psychedelic with Dr. Kurt Rasmussen. Dr. Rasmussen is Chief Scientific Officer at Delix Therapeutics. He joined Delix from the National Institutes of Health, where he led NIDA's Division of Therapeutics and Medical Consequences since 2018. In this role, he directed the Medications Development Program and played an integral role in evaluating the safety and efficacy of pharmacotherapies, behavioral therapies, and devices to treat substance use disorders. All right, now if you've even clicked on this podcast and you are firmly in the there has to be a hallucinogenic effect to have a psychedelic work, I thank you for even being here. In this, psychedelic world, a lot of us have picked sides, like it has to be one way or it has to be another way. And so I'm just very grateful that if you were very firmly in the please don't ever take away the hallucinogenic effects, that you have come with an open mind to listen to this, because as you will hear, the discussion is not about replacing hallucinogenic therapeutics with the non-hallucinogenic ones. It is how we can use both of them to reach an even greater patient population, because as we discussed, there are some patients that for different reasons cannot take something with a hallucinogenic or do not want to take something with a hallucinogenic component, but could still benefit from the healing. And so we have that discussion. Now, before we get to Dr. Rasmussen, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And one last reminder, if you are a physician, nurse practitioner, PA, clinician, therapist, social worker, and you'd like to learn more about how psychedelic therapeutics may benefit your patients, please consider joining the Psychedelic Medicine Association. It is our mission to get you comfortable enough with these medicines to discuss them with your patients when appropriate. You can check us out at the just psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Kurt.
Oh, thanks. Delighted to be here. Thanks for having me.
I've really been looking forward to this discussion. I was actually, for all the listeners, just telling Kurt before we started that usually we talk about things that are clinically applicable, maybe ketamine for depression or something that people can go try now. But what we're going to be talking about today is something that is not yet available, but as if you've been in the psychedelics industry long enough, you know that this is a big discussion as to whether there is a utility in having something that technically is a psychedelic or a version of, the current psychedelics we have that do not have a trip or hallucinogenic component. And I saw Kurt give this talk at Horizons, and it was really incredibly fine-tuned to so many different reasons that this may be useful. And so as you're listening to this, if you are staunchly on the, let's say, the must have a hallucinogenic version side, please keep an open mind, because just think about maybe the most elderly or most conservative members of your family, or whoever would be the least, signing up for that underground journey that we all just did last weekend or whatever. Think about how we're trying to increase access for everybody. And so that's what this conversation is going to be a lot about, is how these may help increase access. So Kurt, I wanted to start by telling people, I found this was not in your bio, but I dug this up in your very helpful website, that you were one of the authors of one of the first publications that attributed the psychedelic effects of these medicines that we often talk about to the 5-HT2A receptor. When did that happen? Can you tell us a little bit about that?
Yeah, that's right. Boy, that was a long time ago. That was I was a graduate student, and that was in the early 1980s.
Wow. Well, thank you for your work in that field. That's incredible. So, I think what gets behind a lot of this debate is that when psychedelics have such a, obvious trip component, there's hallucinogen and all this, a lot of people might forget about or think slightly less about the effects that are going on physiologically. So while we're experiencing, maybe reliving trauma or finding forgiveness or all the things that can happen within the trip, there's actually other things going on in our physiology. Can you talk a little bit about that to start for us?
Yeah, certainly. The psychedelic compounds have very, very powerful effects on, it's called neuroplasticity. But one way to think about it, even more specific than that, it's around neuromorphology. You, the shape of the neurons, the shape and connections of the neurons are actually physically changing. Small, minute, but physically changing. So there are changes in your brain as a result of administration of these compounds that occur. It's not just a sensory and emotional experience, but actually there are physical changes in your brain in different circuits, very specific circuits. And the reason we think that the psychedelic experience, the hallucinations, are not necessarily needed for the efficacy is that we think there are different circuits in the brain that are activated. Those are different circuits in the brain. The circuits in the brain that produce the therapeutic efficacy is probably the prefrontal cortex, very specific neurons there. The psychedelic experience are probably different neurocircuitry.
And so within that, I think we might as well just kind of like get the elephant in the room out now. Like when you say efficacy, I think we're probably talking like efficacy on two different levels, right? Because I'm thinking back to just firsthand psychedelic experiences, and I've come upon certain things because maybe there was a sight or a sound or a vision that I saw. But I also know that, we all have this afterglow that probably has a lot more to do with the physiologic. So when you talk about efficacy, am I correct to assume that we're talking on like, there's like a physiologic efficacy and maybe more of a mystical, spiritual, psychological efficacy?
Yeah, when I say efficacy, I'm referring to a clinical efficacy in a patient population for very particular symptoms. Let's talk about depression or anxiety. There are clinical symptoms of the diseases, and then they vary. It can be cognitive changes or depressed mood, clearly, or sleep changes. And so when I talk about efficacy, I'm talking about changes in those symptoms for patients, an improvement in those symptoms.
Okay, gotcha. So you mentioned neuroplasticity, and I have a question because I think there may be, as I understand it, things that happen to us physiologically that only happen while the medicine is circulating. And I'm talking about like MDMA that turns off the amygdala while the MDMA is circulating. But then it sounds like there's neuroplasticity is something that has a longer lasting effect. Is that correct?
That's absolutely correct. And one of the most fascinating and exciting parts about it, someone can take a medication or a psychedelic or ketamine or anything like that, and there can be long-lasting changes in the symptoms of the patient and long-lasting changes in the neurons in the brain, which is incredibly exciting. It's not at the compound's long gone. What it does is initiate a cascade of events. It lights the fuse, if you will, on a whole cascade of events that change neurons, and they maintain that change structure for days, weeks, months for some people. So that's why we can get these very, very long-term improvements after one administration of a compound. And that's, for psychiatry, that's so exciting because and typically in psychiatry, we've been treating symptoms, trying to improve symptoms, and people have gotten a lot of help from what's out there now. But we're not really curing the disease. If you stop taking the medication, they typically will come back. This is not quite a cure, but a step in that direction, that we're actually addressing the defect in the brain, or what's the problem in the brain, and repairing it in a way long term, and that an effect that lasts for weeks or months. And that's just incredibly exciting for me, and it's going to be great for patients.
Yes, absolutely. And I'm really happy that you brought that up because I think people might think, okay, if we're taking out what we see as the journey part, then are we going back to the regular medical model of take one of these every day? And that seems to be not what you are indicating. So what
Not,
kind of, for these, what kind of schedule do you foresee that these would be used in?
Our hope is they would be used as infrequently as once a week, or even for some people, even less frequently than that, once a month. Ketamine is sort of the guide here, and different people respond with different lengths of time where they get a remission of symptoms. Some it's for a couple of days, some for a week, some for several weeks if you're lucky. So Yes, that's the idea. Our hope is that our compounds would be active. Like you take the pill once a week, maybe less than that, even if we're lucky. But I think that's a noble goal.
Yeah, I think once a week well, first off, significantly better than every day, and then I like how you said, ideally even once a month, and that's kind of more of a flexible thing. And as you said, ketamine is a very good analog for that discussion because I work for a ketamine company, and there are some people who need the maintenance boosters more frequently than others, and the goal is to stretch out the period of time between those boosters, but um, regardless, none of it is every day. This is
Right.
all, there are definite, periods of remission.
And that's so exciting to have that discussion in psychiatry. I spent many years working on novel neuropsychiatric compounds, and it's just so exciting and great for patients that we're having the discussion where someone can take a pill once a week, once a month, and relieve their symptoms. That's wonderful.
And I'm just gonna sneak this in here. Always still probably good to have psychotherapy.
There's no doubt. There's absolutely no doubt. We learned that from depression. SSRIs and other antidepressants can have effects by themselves. Psychotherapy can have effect by itself. But the real efficacy, the magic, is in when you combine the two. And I have no doubt that these compounds uh, will benefit from a psychotherapy associated with it. Absolutely, positively.
Amazing. Okay, excellent. Well, now I think it's a good time for us to get into the reasons that having the psychedelics as we have them, with a hallucinogenic component generally, what may be some of the, I don't want to say downsides, but some of the reasons that that component may limit accessibility for people.
No, exactly. There are people who will not be either willing or able to take the psychedelic medications. Um, for example, an example would be a schizophrenic patient, or even someone with psychotic symptoms, bipolar or other psychotic symptoms, or someone with a family history of it, or prodromal symptoms. And the risk is that you will make those symptoms worse. That it'll be problematic for the patient, like completely bad for the patient. So, for example, right now in the current trials with psychedelic medications, that's an exclusion criteria. If you have any psychotic symptoms or even a family history of psychosis, you're excluded from the trials, and with good reason. And so that would limit who could take that. Another limitation would be someone with dementia, for two reasons. One, can you imagine giving an Alzheimer's patient, who knows how they would react to a hallucinogen? Could be very problematic. And on top of that, as someone with even mild dementia would have a lot of trouble establishing the rapport with the psychotherapist that is needed to do this type of thing. So dementia is going to be could be another exclusion criteria, and another big population of patients that may not be able to take these medications. And then there's a whole population of patients who will not be willing to take them, for personal, religious, moral, whatever reason. I don't care what you say, doc. I ain't taking that. That type of thing. And that's perfectly reasonable. And then there's always the patient vulnerability. When a patient's on the trip, and that's a very vulnerable patient, and that can sometimes lead to problems. So there's a limited, for all its power and promise, there are probably a limit. There's a limit as to how many people can or will be willing to take the medications, the psychedelic medications.
Yeah, I'm even thinking of just the physicality. My grandmother, before she passed years ago, she had anterograde amnesia, so she would have been very confused the whole time. And just physically, I guess she could have done the trip in her hospital bed, but I just think that it might have been very uncomfortable for her. But since she did have this specific type of amnesia from a stroke, that we now know that psychedelics, are being investigated, or at least DMT is being investigated for stroke. Like, what would it have been like for her to have had the possibility to have that kind of neurogenesis healing without what could have been, like you said, a potentially very uncomfortable trip? So I always think about when we have these discussions. I think something else that you had brought up is the limitation on the fact that most of these have to be done in clinic. The ones that have some kind of journey, they have to be done with a facilitator at a location.
Yes.
And that is another, kind of rate limiting factor in access.
Absolutely. And there's people, I mean, that makes it more difficult, time intensive, costly. Will insurance companies pay for that? There's not everyone can afford to take that much time off, to spend that much time in therapy and long periods of time, take time off from work. It's just another barrier to scalability or to access, unfortunately, that accompanies those compounds.
Yeah. Oh, I think we have a dog or a cat visiting us. It's
Sorry.
okay. All are welcome in the podcast, especially if it's a very cute puppy and you're going to bring it up on the screen. No. Oh.
We just got her this week.
Oh my gosh. Sorry, guys out there. You really can't see this very, very cute puppy.
This is Ruby.
Oh, Ruby is adorable. You guys, I would generally cut this out, but that dog is way too cute. So going on from there, another thing that could be something that let's say a journeyless. Now I have like a garbage truck in the background of my a journeyless psychedelic may be able to help is with the fact that there is some abuse liability with some of the current medicines, and I'm thinking directly about ketamine. Most of the others do not have abuse liability or abuse potential or liability or diversion potential, but if you are making something that has no journey, then really there should not be an abuse or a diversion issue.
That's right. We don't anticipate that, and we test the compounds for that. They don't seem to be rewarding in any way, and unlikely to be abused. You never know to put into people, of course, but that doesn't seem likely. And things that are on the periphery psychedelics, like ketamine, is that a psychedelic, but that has a potential for being abused. MDMA can be problematic as well. It's very rewarding, and ibogaine can be problematic. There's some people can abuse that a bit. Typically, like you said, the classic psychedelics are not abused, but we would avoid any. Hopefully, the compounds that are being developed would not have that problem.
And also, I think you mentioned cardiovascular effects. Do you foresee that without the hallucinogenic portion, that maybe some of the blood pressure rise and the heart rate increase would be less likely to occur?
Well, the big issue with the cardiovascular issue with the psychedelics is a different serotonin receptor, the serotonin 2B receptor, which almost certainly does not have anything to do with hallucinations or the effects, but is in the heart and can be very problematic if you take compounds with 2B agonism for a long period of time. Now, hopefully, the psychedelics get around that by not having to take the compound chronically, but it's still an issue that is in the background, and hopefully no one has a bad reaction to it. But it's those are inherent in the psychedelic compounds. Almost all of them are also 2B agonists, and some of the compounds we're trying to develop, the third generation psychedelics, we assiduously avoid any interaction with the serotonin 2B receptor.
That makes sense, and good to know as these get more widespread that yes, we generally think of them as very safe, but there are these things that we're not always thinking of forefront. So thanks for reminding us about that. Now, let's get into the most exciting part of your talk at Horizons, which are kind of the potentials of how something like this could be used. And the first one that struck me that I had not thought about was using something without a journey as maintenance for something that did have a journey with it.
Absolutely. We don't want to be too myopic about this because hopefully both kinds of medicines will help. We need more patient options for patients for sure. And hopefully the psychedelic medications with the hallucinations will help certain set of patients. And hopefully we'll have other non-psychedelic compounds that are neuroplastic that will help patients. And I can see a day when, I hope there's a day when both types of medications are out there, even a range of hallucinations, if you will. Some that produce LSD or psilocybin, a pretty strong trip. Other compounds that have effects but no trip, and even gradations along that, little baby trips maybe even. But I could see so different patient populations can respond to different medications. Even different patients with the same disease but different symptoms could respond to different types of medications. And even the same patient, let's say, this is a possibility, we'll find out. Let's say the hallucinations are needed to kickstart an antidepressant effect. And then, but then you can maintain that maybe with something that's a non-hallucinogenic compound. These are all possibilities, and all good for patients. It'll take years of clinical work to figure this all out and to get the right combinations for different patients. But getting more tools out there, more options for treatment in the hands of healthcare providers and for patients is going to be great,
Yes,
and the
I
goal we're all trying to achieve.
absolutely. And I think that's the key to anything in this discussion is that this is not an either or. This is a yes and. How can we
Absolutely not.
bring all these to, patients
Exactly.
safely?
Study them all and let's see what helps. What helps who different patients will be helped. And for example, the one thing I wanted to bring up about the whether or not hallucinations are necessary, um, they may not be. And for some people, that the hallucinatory experience was clearly, they claim a strong benefit, and I'm, how can we argue with that? But for example, in migraine, for example, the psychedelic compounds LSD, psilocybin have been shown to have very strong effects in migraine. And there's absolutely no correlation between who gets benefit and who has an intense trip or not, or a ego dissolution type of experience. There's no correlation between who is helped with migraine and that. So I think pretty clearly the circuitry can be disassociated, and we think the same as will likely be true for depression or anxiety. But like I said, there may be certain patients uh, that benefit from that. And there may be something like end of life cancer care, where the effects of the antidepressant effects of the psychedelics are first really studied. Now, maybe there the ego dissolution and coming to grips with getting a different view of reality. Now, maybe that might be where it's therapeutically relevant. And in other disease states, it may not be as relevant nor needed.
Yeah, you have absolutely read my mind because that was going to be my next question is that, some indications don't necessarily need that. Now, yes, anybody who wants to be an either or can argue, well, why not have the benefit of it? Like that's, I think a lot of these were discovered is they took them for one thing, ketamine, and then found out, oh, wow, despite us using it for anesthesia or pain or whatever, they were also feeling much better. Well, yes, but that might be a nice bonus if the patient is amenable to that journey. But if not,
Right.
if, like you said, if the thing we're trying to address is, like I said, if it's DMT for stroke and, we just want them to have enough neurogenesis to connect some, the neurons back together that the stroke destroyed, less so I'm trying to cure depression or their trauma or whatever. Or like, I think, and like you said, with migraines, it seems to be, a lot of these central nervous system issues that we could help that don't, maybe the patient isn't depressed and doesn't have these other things, but it's a specific ketamine for pain, another example, a specific condition that may not need that kind of
Yeah, exactly.
psychotherapeutic component.
Right. We want individualized treatments for for different people eventually, and that's what we're hoping for. And the more, like I said before, the more treatment options we get out there to help different patients with different symptoms and different situations, even different stages of the illness, will will be benefit everyone.
Yeah, absolutely. Now, with these medicines that you're researching and working on, like we were talking about with, let's say, MDMA, we know how long it's happening because we experience the hallucinogenic effects. And so, we figure, okay, the amygdala is offline for this more or less this 8-hour journey that we have. In things that you're creating that don't have that, how long do you foresee that, do we were talking, do they have acute effects like that? Or is it more just the lasting neuroplasticity effects?
They have some acute effects, certainly, but it's the long-lasting effects that we're most interested in, and based on our animal studies occurred. There are, like I said, frank changes in the brain that you can measure, and there are changes in animal models of various disease states that seem to last a week or two after a single administration. So we're hopeful that that will translate to people.
And to get just slightly nerdy, it seems like 5-HT2A receptor medicines and NMDA receptor medicines are all leading to neuroplasticity. This is through, I'm assuming, different mechanisms.
You're correct. I think the way to think about it is that there's a common downstream effect that can be entered from different starting points. Uh, Ultimately, it looks like the downstream effects are on BDNF and track B, just to get nerdy, but there are some downstream common effects. But there's different ways to light the fuse, if you will. You can light it with 2A agonists. You can light it with NMDA antagonists. You can light it with non-2A antagonists. There's different ways to get to that final common pathway that produces the neuroplasticity.
And what are some of the indications that you've been, I'm not sure exactly what stage of research, but have you gotten to the point where you're looking at specific indications at this point?
Sure, we're exploring lots of different indications. Depression is an obvious one to start because there's so much work with the psychedelics in treatment-resistant depression. We're looking at anxiety, PTSD. We're also looking at things like migraine. We're also looking at substance use disorders, where there's some really exciting data uh, that that these compounds could be useful there as well. Opioid use disorder, alcohol use disorder. We're exploring those as well.
That
It's really exciting what a range what a range of effects. I mean, everything from typical psychiatric indications, depression, anxiety, to more neurological, if you will, migraine, uh, and even hearing loss. And
Oh, interesting. Yeah,
yeah,
you got me thinking because just before we started recording, I saw the article that just came out about somebody who I know who was, I think he had hemi, like half of his body was paralyzed, and then he did mushrooms and he began to regain use of that side of his body. And so I'm thinking, like, what are the other pain symptoms, or I think the list kind of goes on in ways that neuroplasticity and neurogenesis and those kind of benefits can be useful.
yes, that's absolutely right. And I think different compounds will be affecting different circuitry or different microcircuits, if you will, in the brain, so that different compounds will have different varying levels of efficacy for different indications. And like I said, the indications can be from neurology to psychiatry. Now, if this is all, of course, it's not going to be a panacea, and these are all possibilities that will be needed to careful clinical trials will need to be conducted. But it's very exciting.
It is. And I have one last question, because this is, for some people, they may not want to do it because of the maybe afraid of the journey. But some others, it may be afraid of the side effects. And, for example, I know I know from personal experience, there can be a lot of nausea associated with a lot of these. Do you think that that substances without the journey will affect the serotonin receptor in a way that doesn't affect the kind of gut serotonin in the same way? Or has there been any investigation in that area?
There's every chance that that will be the case. We're we're interacting with certain receptors in the brain that that's like I said, different circuitry, and we think that we can avoid some of the nausea as well.
Incredible. What are there any side effects so far that do seem to be more common with these?
Mm, not really. That hasn't been very problematic. Well, we hopefully will be in people next year with our first compound. So we'll find out. And I mean, and that's it's interesting to want to short circuit the debate. Let's have that debate about hallucinations needed or not. But it's a clinical hypothesis. It's a hypothesis that can and will be tested. So we'll find out.
Absolutely. Well, I look forward to hearing the results when you do try them in people, and thank you for the work that you're doing in trying to get healing to as many people as we can with these populations that maybe psychedelics in the traditional way were not helpful for. And I also want to thank everybody who maybe came to this discussion with a very strong feeling anti, and who sat through the entire thing, and hopefully maybe thought had a new thought or two presented. I always appreciate people sticking around for that. Kurt, would you like to tell people where they can find you in your research?
Sure. So I work at Delix Therapeutics right now, and I'm on LinkedIn. You can find me there. And I before at Delix, I spent most of my career at Lilly, and then prior to that, I was at the NIH working at NIDA. And it's you can find me on LinkedIn or go Google search on my papers.
You can Google search all your papers. I think there were very many of those papers. So, like you said, decades of research back into the 80s when you were one of the first people to find that. That's very cool. I like that little negative
It's
info.
really fun to see it come this far and to be so potentially important as a therapeutic. That's really rewarding.
I love it. Well, that's a perfect place to end. Thank you so much, Kurt, for joining us today.
My pleasure. Thanks for having me.
Absolutely. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review, as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.